Now, this is something I see every week. A patient, let's call him Frank. He's 81 years old. He has an end stage cardiac failure. DNR is in place, and a palliative care referral was made, but that was 3 weeks ago. He was then presented through the emergency department at 2 in the morning. He was acutely distressed, in pain, respiratory rate 28. And the admitting nurse first instinct, a trained instinct, an understandable instinct, is to reach for the resuscitation trolley. Not because the team hasn't read the notes, but because no one has clearly documented what Frank's goal of care actually are. There is no current advanced care plan in the system. The palliative referral has a 2 week wait, and the DNR form was signed by a consultant who is actually no longer in the service. This is not a story about a bad nurse or an incompetent team. This is what happens when system fails to support clinicians in delivering care that is evidence-based, that is legally defensible, and genuinely person-centered. The modern palliative landscape demands more than comfort measure. It demands clinical precision. It demands governance alignment and documentation and communication that can actually hold up under the coronial microscope. Now, here is the assumption I want to challenge today. Yes, I want to challenge today. The assumption is this: that palliative care is primary about comfort. That once a patient is on a palliative pathway, the clinical intensity drops and the documentation burden decreases. That assumption is clinically incomplete. And in some circumstances, it is unsafe. Palliative Care Australia sits at the intersection of complex symptoms management, goals of care, decision making, and legal obligation under state and territory legislation, and increasingly regulatory scrutiny, particularly in aged care, where the Aged Care Act 2024 and Aged Care Quality Standards make explicit reference to dignity and rights at the end of life as measurable standards. The National Safety and Quality Health Service Standards also, specifically Standard 1 on clinical governance and Standard 8 on recognizing and responding to acute deterioration, apply to deteriorating palliative patients just as they apply to any other patient. The obligation to recognize, to document, and to respond does not disappear because the patient has a palliative diagnosis. And the Australian Healthcare Practitioner Regulation Agency is very clear. Scope of practice, clinical decision making, and documentation obligation remain active and accountable regardless of care context. So today, I want to reframe palliative care not as a withdrawal of clinical rigor, but as a redirection of it. It's a redirection towards symptom precision, towards advanced care planning integrity, and towards escalation pathway that are designed for dying well rather than surviving poorly. Let me ground this in what the evidence and the regulatory environment actually tells us. We mentioned it, the scale of the issue. In Australia, the Australian Institute of Health and Welfare reports that around 54% of deaths occur in hospital. And that proportion rises further in aged care setting as well. Data from Palliative Care Australia consistently shows that many Australians who die in hospital do not have advanced care plan, and many have not had a formal goals of care conversation documented. The Grattan Institute report Dying Well found that patients often receive high intensity intervention in the final weeks of life. They mentioned about ICU admission, mechanical ventilation, chemotherapy, just name it, even when this is not aligned with their expressed preferences. This is not a values problem. This is a documentation and communication problem. Now, we mentioned about coronial regulatory and findings. Now, coronial inquests across Australia have identified consistent themes: failure to document goals of care, failure to communicate these goals at handover, or even like delays in administering medications for breakthrough symptoms, and the absence of clear and active plan for terminal phase. The Royal Commission into Aged Care Quality and Safety was explicit. End of life care in aged care was basically inconsistent, under resourced, and frequently under documented. And the reforms that followed, now embedded in the Aged Care Act 2024 and the strengthened quality standards, create direct accountability for services and for clinicians. Now, we heard about PACOP. One of the framework increasingly used in aged care governance is PACOP, known as Palliative and End-of-Life Care for Older People. PACOP is an evidence-based framework designed to support clinicians working with older people approaching end of life. It provides structured guidance on one, identifying the dying trajectory, planning goals of care, assessing and managing symptoms, and engaging families and carers, and documenting care appropriately. Now, PACOP described 5 key domains: identification, communication, symptoms management, care planning, and after death care. It is not a tick box tool, it is a clinical reasoning scaffold. Used well, it supports clinicians to make and document defensible decisions. And it creates evidence trail that holds up under clinical governance review and external scrutiny. Now let's align this with the framework. Now, to when you step back, all of this aligns clearly with the existing Australian frameworks. We mentioned about the National Safety and Quality Health Service Standards, particularly Standard 1, clinical governance. It requires palliative pathway to be monitored and reviewed. We also have Standard 8, recognizing deterioration. It still applies, even when care comfort focus. Aged care quality standards, they mention about particular clinical care and consumer outcomes are directly engaged at end of life. The Aged Care Act 2024 also reinforced rights-based care. They talk about dignity, informed consent, and access to advanced care planning. The AHPRA, the Australian Health Practitioner Regulatory Agency, is clear: your documentation, your clinical judgment, and your escalation decision remain accountable. So when palliative palliative care is delivered well, it is not a step back from clinical care. It is a system that is structured, evidence based, and clearly documented to support decisions that are clinically appropriate and aligned with the person in front of you. We Now we need to set up the expectation here. So I'm going to give you 7 high impact points. These are not theoretical. They are drawn from patterns of practical failures seen in many incident reports, coronial findings, and complaints data all across Australian healthcare services. The first one is identifying the dying trajectory and documenting it. This is the first issue, you know. The first issue is this, you know, the failure to formally identify and document that the patient is likely dying. This is one of the most consequential gaps in palliative care practice because without that identification, no goals of care, no goals of care process is activated. No advanced care plan is reviewed and no anticipatory planning occurs. Now, what it looks like in practice, clinical or clinicians recognize deterioration. They see you see so many things like weight loss or the reduced oral intake, the increasing sleep, the especially the peripheral shutdown, but they do not name it. They often I've read notes like patient continues to decline instead of patient is in terminal phase, and that's it. You know, that linguistic gap has clinical consequences because every decision that follows is shaped by what was or was not documented. Why it was risky? Well, clinically, there are no anticipatory, should I say, there are no anticipatory medication prescribed. No plan for respiratory secretion, terminal agitation, or escalating pain. For a communication perspective, we're talking about handover. It lacks clarity. Nice staff are left managing the dying patient without a framework. From a legal and regulatory perspective, say the NSQHS, we did mention about Standard 8, recognizing and responding to acute deterioration, still applies. And coronial findings have specifically identified that the absence of terminal phase documentation as a failure in clinical governance. So in practice, we need to identify it in practice. So weak practice sounds like this. Patient is unwell, continue palliative measure, review tomorrow. No identification of the terminal phase, no anticipatory medication, and no clear plan. Strong practice is different. The terminal phase is identified and documented with clinical reasoning. We also have goals of care are reviewed and updated. Anticipatory medications are prescribed. Family are informed and the plan is confirmed. So when the signs indicate that a patient is entering the terminal phase, you must name it. You must document it. And you must activate the anticipatory care plan. Now listen, continue monitoring is not a plan for dying. Now, 2, advanced care planning. We're talking about currency, completeness, and accessibility. The issue is this: an advanced care plan that cannot be located, that has not been reviewed, or let's say no longer reflects the patient wishes, has no clinical utility at 2 in the morning. What it looks like in practical sense? Well, in practice, this is what usually happens. There is an active care plan on file, right? So it was completed at the admission, but that was 18 months ago. The patient's condition has changed significantly. But problem? The plan. The plan has not been reviewed. It sits in a paper file. The night nurse doesn't know it exists. Why it was risky? Well, clinically, decisions are made without clear documentation of the patient's preferences. This leads to interventions may not be initiated that are not aligned with what patient would have wanted. We look at the communication perspective. Well, substitute decision makers are not contacted, obviously, and then family arrive after the fact to find care delivered that does not reflected what they believe has been agreed. We look at from the legal and regulatory perspective. Well, the Age Care Act 2024 established the right to informed decision making, and access to advanced care planning. A plan that is not current, or should I say, not accessible, creates regulatory exposure. So in practice, weak practice looks like this. Advanced care plan completed at admission, filed in paper records, not referenced at handover, not accessible to after-hour staff, not reviewed after deterioration. Compared to what we call strong practice, which is quite different. The advanced care plan is reviewed at every significant change in condition. It is updated and documented in the clinical record. It is visible, flagged at handover. We also have substitute decision maker details are confirmed, and the tools like PACOP support identification and structured review. So the clinical rule is this. Advanced care plans are living documents. A plan that predates the current clinical trajectory is not a current plan. You need to review it. You need to update it. You need to document the conversation and make sure it is accessible when it is needed most. 3, symptoms assessment in terminal phase. Pain is the symptoms most clinicians prepared for, but the terminal phase does not present with pain alone. It presents with a constellation of symptoms. We've got dyspnea, respiratory secretion, terminal restlessness. We mentioned about nausea and basic care needs like oral comfort. These are not symptoms to react to. They are symptoms. It is 3 in the morning. The patient develops noisy respiration. The nurse calls the on-call doctor, and there is no anticipatory order. The doctor is unfamiliar with the patient, and 45 minutes, the family is at the bedside. This is a preventable failure, a clinical failure, and a human one. So, if we apply PACOP framework, these make the assessment make it clear, symptoms management in the terminal phase must include anticipatory prescribing across 5K domains. We mentioned about pain, dyspnea, respiratory secretion, nausea, and agitation or restlessness. These medications should be 1, prescribed, 2nd, accessible, and clearly documented before they are needed. So, if you look at the weak practice, this is what it looks like. PR morphine charted for pain only. No anticipatory orders for secretion or agitation. No clear administration pathway for after hours care. A doctor is called at 3 in the morning without a clear patient's history. Now, if you compare that one with the strong practice, it's obviously quite different. An anticipatory medication chart is completed, covering all 5 symptoms domain. Administration guidelines are documented. Nursing care are supported to administer understanding orders where appropriate, and structured tools support assessment and documentation. So the clinical rule is this: anticipatory prescribing is not optional in what we call terminal phase. If medication cannot be administered promptly when symptoms occur, the clinical plan the, the clinical plan is obviously incomplete. Number 4, goals of care. The issue with goals of care is mainly boils into conversation. But the documentation of those conversations often is incomplete. It often does not capture one, clinical reasoning, who was present, what information was provided, or what was actually agreed. So, what does it look like in a practical scenario? This is um, we look at the notes. It would read as family meeting held, something like that. Family aware for palliative management. That is not a goals of care record. That is only a notation. So it does not tell you who was present, what prognosis was communicated, and what questions were asked. We also doesn't emphasize what options were discussed or say what the patient's preferences were. So in a governance structure, in medical legal context or in and in regulatory review under aged care quality standards, a notation is actually not evidence of progress. Okay, so if you look at if you compare it with weak practice, it would somehow look like this: family meeting held, palliative approach agreed, no record of who attended, no record of what was communicated, no documentation of prognosis, no record of patient's preferences, and no clarity on what the plan actually involves. But if you compare it with the strong practice, it's quite different. It involves documentation that has date and time, who attended, what prognosis was communicated, the patient's expressed preferences, identification of the substitute decision maker, the goals agreed, a clear escalation plan, and a documented follow up. This includes information provided to the family. So, in clinical rule, would be this: a goals of care conversation that is not documented with clinical reasoning and participant detail um, has not been documented. Write a note as if a coroner will read it, because sometimes they will. Number 5, we mentioned about handover. So the issue of handover is this: palliative patients are often deprioritized in handover. There is an assumption that the plan is basically static. That because the patient is not for active intervention, there is less to communicate. That assumption is wrong. So, what it looks like in the practical assessment, listen to this. This is what I often encounter. So, handover often sounds like this: Frank, bed 4, palliative, for comfort measures only. And that is it. The incoming nurse does not know the current symptoms burden. When pain was last assessed, whether medications were effective, whether the family has been updated, whether the breathing has changed, or what the escalation plan is if Frank deteriorates overnight. Why it is risky? Well, clinically, symptoms in the terminal phase change rapidly. Okay. An 8-hour gap in assessment and response is not acceptable. From a communications perspective, incoming staff have no baseline. They cannot detect change, and the patient experiences the consequences in the gap between shifts. So, if you compare the weak and the strong practice, weak practice sounds like this: palliative for comfort, no symptom status, no escalation trigger, no family update, no overnight plan. Strong practice is different. Handover includes current symptom status, um, the status of all, basically 5 domains, the last medication and response, family notification, clear escalation pathway for symptoms breakthrough, and the name of the on-call clinicians who knows the patient. So the clinical rule is this: palliative care handover must include active symptoms reporting. Let's say for comfort measure is a goal, not a clinical summary. 6, family and carer engagement. So the issue with this is basically family and carer engagement in the terminal phase is often treated as a pastoral task. What does it mean? Something sort of like just a supportive but not essential. So, under the current Australian framework, it is actually both. It is clinical and it is accountable. So, under Aged Care Act 2024 and framework such as PACOP, family and carer engagement is a right based obligation. Now, it must be structured, documented, and responsive. So in clinical practice, this is what it looks like. A patient dies at, let's say, 4 in the morning. The family arrives at 7. They discover no one contacted them when the terminal phase was recognized in the previous evening. The clinical notes state family not present. So there is no record of a contact attempt, no record of what the family understood, and no record of whether they wish to be present. This actually create harm, not only for the family, but actually within the system, because absence without documentation becomes governance gap. If we mentioned about the weak and the strong practice, so the weak one would look like family not present, record of contacts attempts, no records of preferences, no documented discussion about the terminal phase. But on the strong practice is quite different. So family preferences are documented early. Documentation is in situ during care planning and after care planning. Recognition of terminal phase, contact is made, a conversation is documented. The family's decision to also like to attend or not to attend is clearly recorded. It has to be documented. And support is offered: presence, pastoral care, and aftercare processes, all explained and documented. So the clinical rule is this: family contact at the recognition of the terminal phase is not optional. Document the contact, document the conversation, document the decision. A family's absence from the bedside must be a documented choice, not an undocumented gap. Lastly, number 7, aftercare death. The issue with this section is that clinical documentation does not end at the time of the death. The post death record is part of the clinical record. It includes the cause of death, documentation, bereavement care, and service review. And it forms part of the clinical governance cycle. So, what it looks like, this would mean that, let's say, a patient dies, the nurse completes the body care, notifies the family, and documents. It says patient passed away around 2000, family notified, body care completed. That record is incomplete. It does not describe the hours leading to the death. It does not reflect the symptoms management provided, and it does not show the conditions under which the patient died. So, under aged care and quality standards and applicable state legislation, organizations have ongoing obligations: death, documentation, assessment of reportable death requirements, and bereavement follow up. So, comparing the weak and the strong, weak practice looks like this: decrease or decrease, what am I talking about? Disease at zero, at 2400, no record of symptoms management, no documentation of family presence or notification timing, um, no bereavement referral. What strong practice should be is quite different. There is a clear, detailed record of terminal phase, time of death is documented, the clinician present is recorded, family contact and timing are documented. Reportable death status is also considered and recorded. And lastly, the bereavement support is offered and also documented. The case is flagged for clinical governance review. So the clinical rule is this: the death note is part of the clinical record. Write it with the same precision. You would apply to a resuscitation event note, because the quality of end of life documentation reflects the quality of end of life care. Let's talk about case scenario. Okay, so let me walk you through a composite case. This is drawn from, should I say, real patterns seen in coronial findings and complaints across Australian services. And it shows what happens when these 7 points fail together. Let's say scenario number 1. So, Margaret, 84, residential aged care. Margaret is 84 years old, yeah, and she has advanced dementia, ischemic heart disease, and recurrent aspiration pneumonia. There is a DNR on file signed 18 months ago by her daughter as a substitute decision maker. Now, day 1, um, 900 hours. Are in documents. Margaret not eating, increased sleep, mottling to lower limbs, no escalation, no documentation of terminal phase, no review of palliative plan. Day one, 1400 hours, afternoon handover. Margaret is unwell for comfort only, no symptom status, basically no medication, no family contact. So day one, 2200 hours. Night RN notes mention increasing respiratory secretion, but no anticipatory order for secretion management. So on-call GP contacted, unfamiliar with the patient, medication order delayed 55 for about 55 minutes. Now day two, 100. So Margaret becomes distressed. Family not contacted again. So, but the note states patient appears uncomfortable. Day two, 0340, Margaret dies. Family not present, no record of contact attempt. Death note states pass away peacefully. Day two, 0900, family arrives. They learn of her death. There is no explanation for why they were not contacted. No bereavement support offered. A complaint is lodged. So, looking at that case scenario, what was failed? The terminal phase was recognized but not named. There was no structured identification process, no anticipatory prescribing, handover, lack clinical content. Family contact obligations were not met. And also, the death note does not reflect what actually occurred. This is not this is not a complex case. Margaret's death was expected. The failure was not in diagnosis. It was in the system. Um, it was in the documentation and in the communication. It was also in the anticipation and other matters, you know. So the complaint was upheld. The Aged Care Quality and Safety Commission identified multiple breaches of the Aged Care Quality Standards. The service was required to basically implement a mandatory palliative care education program and a revised clinical documentation protocols for the entire organization. Now, let me leave you with six principles. Now, these six are non negotiable. They are basically non negotiable clinical standards for palliative practice. Now, principle number one is name the trajectory. You need to use clinical language, clear clinical language, and document, let's say, terminal phase identified. You also need to activate structured frameworks such as PACOP and do not rely on euphemism that obscure clinical reality. Principle number two is anticipate and don't react. So, symptoms management in the terminal phase requires medication to be prescribed. It needs to be prescribed in advance. So, reactive prescribing creates preventable suffering. Principle number three is keep the plan current. Advanced care plans, goals of care, DNR, and others. These must reflect the current clinical trajectory. So review them at every significant change. Principle 4 is document the reasoning. So a note that records the action without the reasoning is incomplete. So write why the decision was made and not just what was done. Principle number 5 is close the communication loop. We're talking about handover, family contact, escalation. So each loop must be closed and documented. Assumptions at shift change create risk. And principle number 6 is governance doesn't stop at death. So post death documentation, reportable death assessment, bereavement follow up, these are clinical obligations, not afterthoughts. Okay. If you apply these principles consistently, you do not just improve documentation, you improve clinical clarity and you reduce risk. It also supports patients to die in a way that is safe, documented, and aligned with their wishes. I want to come back to where I basically started. Frank, at 2 in the morning, remember? A nurse reaching for a trolley, not because she didn't care, but because the system had not given her the framework to care well. This is what I see every week. Um, not malicious practice, not incompetent clinicians, clinicians working in a systems where palliative care governance is not as visible, is not as structured, and not as accountable as acute care. The the modern palliative landscape is changing. The Age Care Act 2024 has actually raised the bar. The NSQHS standards apply, and the Australian Health Practitioner Regulation Agency, or AHPRA, has always been clear. Practice within your scope, document your reasoning, escalate when required. Frameworks like PACOP give you a way to do that well in end of life care. So before you leave this video, open your most recent palliative care entry. Just ask yourself, did I name the trajectory? Does this reflect the current goals of care? Have I documented who was contacted and what was agreed? And is the clinical reasoning clear? If the answer is no, that is your starting point. Okay? Not blame, not shame, a system gap that you now have the tools to address. Clinical excellence in palliative care is not about doing more, it's about thinking precisely, communicating clearly, and documenting accountably, and keeping the patient and their defined wishes at the time of every decision, on every shift, in every setting. Okay, so I'm Ed. This channel exists because clinical practice should be grounded in evidence, accountable to governance, and focus on patient safety. If this was useful to you, follow the channel and share it with your team. Next time, we continue.